Hello, good afternoon, everyone. Welcome to the session on the breathless child. Could we please move in front? Thank you. Okay, we are going to start right now. We are a little bit late, but we'll catch up. My name is Rebecca Nantanda. I'm a general pediatrician. I work with Kerry University Lung Institute, mainly as a researcher and also a postdoctoral research associate with Liverpool School of Tropical Medicine. And this afternoon, I'm privileged to moderate this session on a breathless child. And I think we all agree that children should survive and thrive. But the diseases we are going to discuss this afternoon, asthma, which is the most communicable disease in children, and pneumonia, most common non-communicable disease in children, and pneumonia, which is the most common communicable disease in children, are actually standing the way of children's survival and thriving. So we are privileged to have two people in the room, well-established researchers and scientists who are going to take us through this discussion. And first, we are going to discuss asthma. So I'm privileged to introduce Ines Asher, who is a professor of pediatrics from University of Auckland in New Zealand, and a respiratory pediatrician with Starship Children's Hospital in Auckland. She has several awards. One she mentions in 2003, where she was awarded the Feast of the New Zealand Order of Merit for services to pediatrics. And in 2007, the Health Research Council Lilly Medical for her research in leadership. She's the chair of the Global Asthma Network, and she's been a global researcher and leader in asthma for 27 years. That is since 1992. Those of you who have had an opportunity to read and know the work of the ISAC studies, she is the professor behind all that. In 2017, she was appointed the World Health Organization as an expert on chronic respiratory diseases with their inaugural expert panel meeting on non-communicable diseases. The best of all is that she's very passionate about children. She wants to see all of them enabled to reach their full potential in New Zealand and other countries. Ines, you're welcome to take us through this discussion. Thank you.
Thank you very much, Rebecca, for your kind introduction, and I feel very honoured to have been invited to the union meeting here to talk on this topic. The Global Asthma Network, GAN, was established in 2012 following the work of ISAC and the Union. And our steering group includes people from ISAC and the Union, as noted here, and the Union has been a major funder of GAN. So GAN has a wide global reach with 135 countries at 377 centres, that reach that extended the networks of ISAC and the Union. Topics I'll touch on in this talk will be focusing on children, but not entirely, the burden of asthma, risk factors, essential asthma medicines, policy responses, advances in treatment, and future research, all in less than 20 minutes. About 340 million people have asthma, and asthma causes disability and death in all ages. I'm going to show you a video in a minute of the 3-year-old child who has preschool asthma. The following speaker will be talking about pneumonia, and when we're seeing a breathless child, we need to distinguish these conditions. So a child with asthma has expiratory wheeze, prolonged expiration, is not systemically unwell. So I'm just going to show the video here. which I need just to click on this and listen, look and listen.
Three-year-old boy has been coughing and wheezing for 3 days since he had a cold. He is eating and drinking okay. You can see that he has quite significant subcostal and intercostal recession, abdominal breathing, and a respiratory rate
of 50. Deaths from asthma are as common as malaria. It's important to note this fact because malaria has had much more global attention, where research has been prioritised and prevention strategies brought in. So we wanted to share with you that each day there are 1,150 people die from asthma around the world. 40% of these are from India, even though the prevalence here is low at about 5%. And each day there's comparable deaths from malaria. This video shows you a teenage boy who has life-threatening asthma. If he wasn't receiving the treatment he's getting in emergency medical care, he would die.
This 14-year-old boy is a known asthmatic and became wheezy last night. He has never been this bad before. The history came from his dad, as he was too tired to talk himself. He is not distressed, but see how he looks tired. Also notice how he's propping himself up to breathe easier, and he is bobbing up and down with the effort of breathing.
Asthma also causes disability in children. Disability-adjusted life years, DALYs. Globally in children, asthma is in the top 10 causes of DALYs for age 5 to 14. And in 10 to 19-year-olds, asthma has become a more common cause of DALYs. What do we know about global asthma in children? And what can we do to improve outcomes for them? Well, this is addressed in the Global Asthma Report 2018, and I encourage you, if you haven't already, to visit the website, and you can download the report. It's all free, 92 pages in colour, but the website is also available. And this addresses the issues I'm talking about today, or most of them. So going back to ISAC, which also appears in the Global Asthma Report, I want to tell you that ISAC was a study done on 2 age groups of children around the world, 6 and 7-year-olds and 13 to 14-year-olds, who've completed written questionnaires at school. We had 2 phases to the study. One was 1995 to 1996, and this is the later phase here, phase 3, in 2002 to 3. And this is the latest global data we've got on prevalence of asthma. This map and the ones that follow show the older age group. This shows prevalence of cardinal symptom of asthma, wheezing in the last 12 months, or what we call current wheezing, with the rates of prevalence around the world. And you'll see my country, New Zealand, in the bottom right, red stars, high prevalence there. That's one of the reasons we're so interested in asthma in New Zealand. UK, where a lot of people here are from as well, high prevalence. You'll see the lowest prevalences actually are in this part of the world mainly. But we did see high prevalences as well in some low and middle income countries, which was a surprise, with moderately high rates in Africa. There are large variations around the world. A different picture emerges if we look at severe symptoms among those with current asthma, and perhaps this correlates with those death rates we've seen certainly in India, with symptoms of severe asthma among current wheezers. And we'll see that the highest rate of current wheezing amongst those, severe asthma symptoms among those who are currently wheeze is occurring mainly in low and middle income countries, right up our alley here at the Union Conference. Is asthma prevalence changing? Good question. We're the only studies that's been able to address this on a global level from 1996 to 2003, 56 countries, and we see here different patterns, and our high in prevalence countries like New Zealand In the UK, actually going down or staying the same. But many areas of the world where prevalence is increasing, including many sites in low and middle income countries. So in summary, the data I've shown you to date, and before ISAP began, there was only a handful of studies around the world about asthma prevalence. Asthma occurs everywhere in the world. It's more common than was previously thought. There were large variations in prevalence. Asthma overall was increasing. Increases were more common in low and middle income countries, and asthma was more commonly severe there, and association with atopy was weak. Most of the studies around atopy and asthma have been done in high-income countries, and there's really been relatively less investigation of relationships of factors with asthma in low and middle-income countries. So this points to environmental factors being more important here than atopy. So we did an environmental questionnaire as well as part of ISAC, and these were a summary of our findings. Positive associations with having asthma symptoms were tobacco smoke, no surprise there. Open fire cooking, no surprise to those of you who see a lot of it. Farm animals near the home, high intensity truck traffic, dampness in homes, burger fast food intake, obesity, paracetamol or antibiotic use, migration to a higher prevalence country, and greater family size for severe asthma. The negative, potentially protective associations were breastfeeding in low and middle income countries and fresh fruit and vegetables. What about genetics? In the last 10 years ago, everyone thought genetics would answer everything. We do know that asthma often runs in families, but although a number of genetic variants influence risk of asthma, they only explain 4% of the heritability. So again, we come back to environment and perhaps the environmental influences on the gene, epigenetics. So in summary, how to prevent asthma at this point if we're talking about environmental factors? We definitely know that to have no exposure to tobacco smoke in utero and the very early life is absolutely proven, and all the data is consistent for throughout life. The ISAC study shows that we should be focusing on these particular things now, although they're not what we call proven because they're associations. To avoid open fire cooking, high intensity truck traffic, damp and mould in homes, burger fast food intake, obesity, and breastfeeding is always helpful for children, but the protective effect for asthma has only been shown in low and middle income countries, and eat more fresh fruit and vegetables. So I'm now moving from that epidemiology to talk about asthma essential medicines. There's been a lot of talk about TB medicines here. We've got to talk about asthma medicines as well at this conference. It's really vital. So essential asthma medicines need to be quality assured. Most of the essential asthma medicines are given in an inhaled route, using an inhaler. Most commonly, the meter-dose inhaler is the inhaler used. This shows you a schematic diagram of that, and most of you will be familiar with this, but I wanted to point out there are a lot of components here that need careful manufacturing, and any one of these things not working properly could mean that we don't get the spray that we want. We need a spray that's inhalable, particle size inhalable to the bronchi, and if that doesn't occur, the meter-dose inhaler is useless. So we need to have quality assurance of the inhalers that we're making available to our patients, and there's not good systematic processes for that at all around the world. Okay, quality assurance is important, but are the medicines actually available? Well, we need to turn here to the work by Zahir Babar and others from the Union that was done in 2011. They studied 50 low and middle income countries, and this here shows where they found these inhalers available in those countries by on-the-ground research. So blue is salbutamol and the grey is inhaled corticosteroid. The middle one there, National Procurement Centre, is where the stocks for this country are, and so without that being up to 100%, you could potentially run out of these medicines in the country. There are Inhalers available in private pharmacies, that may be private supplies and public hospital pharmacies. But these are very suboptimal, aren't they? If we're trying to get everyone with asthma to have accessibility to an inhaler. If drugs are available, are they affordable? Again, we look into the same study. This is with one example of the results, looking at beclomethasone inhaler, and the x-axis is the number of days of the minimum wage to buy one. The brown columns are the generic, and the blues, surprisingly, the innovator product, which is sometimes less expensive. So here we see that it may take 2 days to 2 weeks to afford a meter-dose inhaler, which is very expensive. But unaffordable asthma medicines are not just a problem in low and middle income countries. The cost of a steroid inhaler without insurance in the USA varies from $139 to over $300, which is actually about a 20th of the cost in my country, New Zealand, to buy over the counter without any insurance. So it's a problem worldwide in lots of countries. So the Global Asthma Report, again, it addresses these issues. It's vital to have policies everywhere in the world to enable available, affordable, quality-assured essential asthma medicines to reach everyone with asthma, to improve their lives and to reduce the global burden of asthma. Just a little bit more on medicines in children. So an inhaler with a spacer is the treatment of choice for children. For the preschool child, usually under the age of 3, we recommend a mask because they're not able to reliably put their mouth around a mouthpiece, but as soon as they're old enough, they should do that. And the picture on the right shows a boy with a homemade spacer from a drink bottle, and this is an option in low-resource settings where you can't afford or acquire commercial-based spacers, and the method for these have been shown to be equally effective to a commercial spacer if they're prepared correctly, and the instructions again are in the Global Asthma Report from Professor Heather Czar from South Africa, who's led this work. Now, a little talk about preschool wheeze, which is a very pressing and interesting area for paediatricians in particular. So, of those who have wheezing in the preschool ages, which we normally tend to say about 1 to up to 5 is the preschool roughly, and certainly in my country that's what we use. And of those who have wheezing in that age group, only about 40% of them go on to have what we call asthma at school age and beyond. But we don't know which 40%. That's the problem. So what do we do? So one of the ways it's been approached, and there are different approaches by different bodies in different countries. In New Zealand we have these 3 categories: infrequent preschool wheeze, less often than 8 weeks, frequent preschool wheeze, and then we can try in that group asthma medicines, particularly the inhaled corticosteroids, to reduce the frequency. If they respond to those medicines, we call them in New Zealand preschool asthma. That's not necessarily a widely used approach, but I think it's a very pragmatic, good approach, because if someone's using asthma medicines and it helps them, it also opens the door and it's very important to get the asthma education for those children at that time. Once they get to school age, we don't know which of those are going to go on to have asthma or not, but we then put that diagnosis behind the child, and then we'll approach asthma as a new diagnosis when they get to school age. Are there long-term sequelae of undertreated asthma in children? Well, of course there are. In childhood, the child may be unable to do all activities for their age. We're talking about undertreated asthma. This doesn't occur if you're well treated. Unable to do all activities for age, poorer education due to missed schooling, poor fitness, disturbed sleep, of course that affects the whole family, and death. Well, death is rather rare from asthma is rather rare in the youngest children, but it starts to become more common in older teenagers, but it could occur at any age. And so we want to treat children so that they don't have any of these outcomes, and that can be achieved with good asthma management. The study in Melbourne looked at children with severe asthma followed to adulthood aged 50 years and found an increased risk of developing COPD. So yes, asthma in children is really important now and in the long term. So coming to policies, we're focused here in this meeting with TB, but with asthma as well, about national strategies. The most effective national strategy that's been most well documented and successful is from Finland. And in there, they brought in a national asthma program led by Tari Hartala in 1994. And I want you just to look at the top line, and this is the y-axis is costs in million euros. And you'll see a gradual falling of costs. Now let's just tease that out. So first of all, deaths fell 5.4-fold, fantastic. And the bottom blue thing is the area is lost productivity. That fell, lost productivity is a big cost for asthma and for the patients and for the country. But the part that increased it was outpatient pharmaceutical costs. So this shows if you actually use a lot more medicines, effective medicines, you'll actually make people weller, can work more effectively, great for them and for the economy. So this is a great model to look at. So in 2013-14, GAN emailed 112 countries who are in our network, and we found that national strategies were only occurred in 25% of countries, but they were more common in high asthma symptom prevalence countries. Mostly they were found there than in low prevalence countries. So again, more work to do in this area. We need some national policies. Policies are needed to improve asthma outcomes in each country and state. That's our goal. Now, what about new asthma medicines? We've had a lot of the old ones around for a while, some for very many decades. But I'm just going to talk about two new approaches with older medicines, the inhaled corticosteroid LABA, which is now available as a combination, and a fast-acting LABA combination is actually recommended by WHO since 2017. And the SMART approach, single maintenance and reliever therapy, is now an approach that is recommended for moderate asthma in adults. And then the combination, as needed, there's some studies recently showing that this is a new approach that can be used for mild asthma in people who are 12 years old and over. And that's the new GENUS strategy 2019. So this is an approach that's coming in for asthma. It'll remove the issues around compliance tremendously that have always bugged us with trying to prevent asthma. But the issues are trying to provide inhalers that are low enough cost, as well as quality, of course, and that's a work in progress that we think is achievable before long. There's also the anti-IgE monoclonal antibody, omalizumab, for the very few with very severe persistent asthma that's atopic, and the really new approach with the anti-IL-5 monoclonal antibody, mepolizumab, which I personally haven't used yet at all in children. What about some research priorities? We need to continue to look at methods of improving the availability, pricing, affordability and accessibility of essential asthma medicines. Look at working out the best models of care for asthma in different settings. Surveillance of burden of asthma and management, and environmental influences on asthma. And these two bullet points are very much the focus of GAN at the moment. Epigenetic changes in asthma, and the applicability of the combination of ICS LABA in children 11 and younger. The European Asthma Research Innovation Partnership put out these research priorities in regard to diagnostic and predictive tools, neurobiological markers of asthma, genomics, proteomics, metabolomics as tools for diagnosis and or monitoring, tools to measure volatile organic compounds and exhale breath, and importantly, and I've sort of touched on this earlier, prediction of future asthma in preschool children with reasonable accuracy. We're not there yet. So I'm coming back to the Global Asthma Report. Please look there for some summaries of these issues. And what's the Global Asthma Network doing next? Well, we're actually underway and have completed data collection on GAN Phase 1 surveillance, which is repeating the work that's been done by by Isaac in 2003. Gosh, it's more than 15 years since that data came in. And we're adding studies of adults and of management. So watch this space, and we're going to be able to provide new data, not only for research publications, but in the next Global Asthma Report. So I'm just going to finish with an optimistic note, because I think if we do all the things we already know to help asthma, we can work towards a world where no one suffers from asthma. Thank you.
Thank you so much for that presentation. Please keep your questions and comments. We'll have the questions at the end of both presentations. I now have the privilege to invite the next speaker, Matthew Kelly, who is an assistant professor of pediatrics and global health at Duke University in the United States of America. He has previously worked in Botswana in one of the children's pediatric hospitals, and he has done a lot of research around pneumonia in children who are HIV exposed and HIV infected, looking at pneumonia, the risk factors around that, mainly in low and middle income countries. His current research largely focuses on the impact of respiratory microbiome, on the risk of colonization by potential pathogens of pneumonia during infancy. And just like the previous speaker, we are privileged that he sits on the WHO panel for pneumonia for reviewing guidelines. So I think we're in the right hands when we are going to make some remarks or some requests. So Matt, you're welcome. Please take us through the next session on pneumonia. Then we shall have the questions later.
Thank you very much, Rebecca, and I'd also like to thank the union for inviting me here to give this talk. So I also am charged with quite a lot in the next 20 minutes, so I'm going to be talking about progress that we've made in preventing and treating childhood pneumonia over the past several decades, and continued challenges that we have with regard to this diagnosis and treatment of this infection. I have no conflicts of interest. So over the past 20 years, we've really made remarkable progress in preventing deaths from childhood pneumonia. In 2015, roughly 880,000 children died of pneumonia, and that was a roughly 50% decline from the almost 1.8 million children who died in 2000. There were a number of factors that contributed to these gains. Certainly, the development and widespread use of Haemophilus influenza and Streptococcus pneumonia vaccines has played a major role, but we've also seen a reduction in a number of key risk factors for pneumonia. For instance, maternal combination antiretroviral therapy has led to a dramatic reduction in HIV infections among infants, and we've seen a roughly 50% decline in the number of pneumonia cases among HIV-infected children. We've also seen improvements in access to medical care, and I think a good example of this is that over this period from 2000 to 2015, the number of children who were hospitalized with pneumonia nearly doubled across the world. And then finally, with socioeconomic development, we've seen some small gains in other key risk factors, including some declines in the proportion of children exposed to indoor air pollution in some regions, although obviously this is still a major pressing concern for child health. So where are we today, or at least in 2017 when we have our most recent data? Pneumonia is still the leading infectious killer of children. It resulted in over 800,000 child deaths in 2017 alone. And it's a disease that is very strongly linked to poverty. So more than 99% of these deaths are in low and middle income countries, and the overwhelming majority of those are in sub-Saharan Africa and here in South Asia. And what we've seen over the past several decades are that pneumonia deaths have been increasingly concentrated in a relatively few countries. India, which has by far the world's largest population of children, contributes 150,000 deaths each year from childhood pneumonia. And you can see the other high-burden countries on this slide. And so certainly for us to continue to make gains in reducing global child pneumonia, we're going to have to focus on these high-burden countries. We've been less successful in preventing pneumonia deaths among our most vulnerable and youngest children. So in neonates, we've seen less of a decline in pneumonia mortality. And it's now to the point where 10% of all under 5 child deaths are from neonatal pneumonia. Like neonatal sepsis, neonatal pneumonia is typically broken into early onset disease during the first week of life and late onset disease from day 7 to day 28. And this is useful both from an epidemiological and a clinical standpoint. So early onset disease typically results from intrauterine or intrapartum exposures, while late onset disease results from exposures after birth. In both age groups, though, neonatal pneumonia presents nonspecifically and can be challenging to diagnose. It's often accompanied by general signs of sepsis and relatively nonspecific features. This slide reviews the etiology of pneumonia in children, and what you'll notice is that etiology varies markedly by age. So focusing first on neonates, bacterial pathogens cause the majority of these cases, and during the first week of life, group B strep and enteric gram-negative bacteria like E. coli are responsible for most cases. As you move later in the neonatal period, that's when we start to see more typical pneumonia pathogens such as pneumococcus and Staph aureus become major causes of pneumonia. Viruses are overall a less common cause of pneumonia in neonates, but certainly during the first week of life, congenital viral infections like CMV, HSV, and rubella can present with pneumonia. And then RSV and rhinoviruses become major causes of neonatal pneumonia during that second half of the neonatal period. Mycobacterium tuberculosis is a rare but frequently fatal cause of pneumonia to be aware of. And then in infants and older children, I'm going to present some of the data, but it's now clear that viruses really are the dominant pneumonia pathogens in this age group, and really RSV is one that stands alone. Certainly rhinoviruses and other respiratory viruses also play significant roles. Strep, pneumo, and Haemophilus influenza are the dominant bacterial pathogens in this age group. And of course, tuberculosis, pulmonary tuberculosis, is an important cause of pneumonia in these older children. And then we need to keep in mind that HIV-infected children, certainly pneumocystis pneumonia is still frequently a cause of fatal pneumonia in these children. So how do we diagnose pneumonia? In most settings, it's really still based on clinical criteria. And the most frequently used case definitions are those that were developed by the World Health Organization in the 1980s. These really were developed for use by non-physician providers who were seeing children in primary healthcare facilities without access to radiographic services. And so they're based on clinical signs and symptoms as opposed to auscultation or chest x-ray findings. The experts who developed these WHO case definitions emphasize sensitivity over specificity. So the idea here was they really wanted to identify as many children as possible who could potentially have pneumonia and who could potentially benefit from life-saving antibiotics. And that was at the expense of including children who have other conditions that don't necessarily require antibiotics, such as upper respiratory infection or malaria. And use of these case definitions in these settings, coupled with antibiotics, demonstrated mortality benefit. So there really is a lot of benefit to using these definitions in the right settings. But I also want to talk about some diagnostics that aren't as widely available. And of course, the first one to start with is chest x-ray. So it's been now 130 years since the first x-ray was obtained for medical use, and it still remains the standard imaging modality for childhood pneumonia. Most would still call it a gold standard for pneumonia, despite the fact that we know that it has a high false negative rate, meaning a substantial proportion of children who have pneumonia will have a normal chest x-ray. Chest x-ray also has a number of potential drawbacks that make it difficult to implement widely, particularly in low-resource settings. First, it is associated with ionizing radiation, which we know young children are more susceptible to. X-ray machines are typically large and clunky, and so it makes it difficult to transport it to remote areas. And then obtaining and interpreting these images requires technical expertise that is not often available in many settings. So with this, there's a lot of interest in developing other imaging modalities to diagnose pneumonia. And one that's received quite a bit of attention is long ultrasound. So we've seen substantial advances in ultrasound technology over the past decade. And there have been a number of studies that have shown that ultrasound can diagnose even early pneumonia using basically looking for consolidation that is extended out to the pleura, which is the case in most cases of pneumonia. Ultrasound has a number of advantages over X-ray. There's no ionizing radiation, and high resolution, freely portable ultrasound devices, low-cost devices are actually widely available at this point. It's not perfect. There are false positives, particularly with atelectasis. And of course, we need to study this more. Most of the studies that we have to this point have had relatively small numbers of individuals with pneumonia included in them and have typically had skilled sonographers performing these studies. So we really need more work on this before we could use this more broadly in low resource settings. So let's now talk about actually establishing a microbiological etiology of pneumonia. And before we get into the details, I wanted to just as an aside, say that I think there are a number of characteristics of pneumonia that make it inherently challenging to diagnose and identify, and our understanding of pneumonia pathogenesis is actually still evolving. So first, we have difficulty in obtaining lower respiratory tract samples non-invasively that aren't contaminated by upper respiratory tract samples. Now that may seem obvious, but this is a significant problem in children who are frequently colonized in the upper respiratory tract by respiratory pathogens. We also, through recent studies using next-generation sequencing methods, know that the lungs are not sterile. They have a complex microbial community, and we believe that that microbial community is transiently colonized by potential pathogens from the upper respiratory tract. And so this really has brought into question what was for a long time, our idea of pneumonia pathogenesis involving invasion of a single bacterial pathogen into a sterile lower respiratory tract. So really, these studies have forced us to question our entire understanding of pneumonia pathogenesis. Over the past century, we've seen a number of trends in pneumonia etiology studies that I've tried to summarize on this single slide. So in the 1900s, most pneumonia etiology studies involved direct sampling of lung, either through lung aspirate or autopsy in fatal cases, whereas studies in the 2000s have really shifted to obtaining non-lung specimens, so sites distant from the lung, and obtaining body fluids from those sites without any direct sampling of the lung. This has, of course, been primarily to avoid invasive procedures, but it has certain implications that we're going to talk about later in this presentation. Previously, culture was really what was primarily used, and that has high specificity for establishing a diagnosis of an etiologic diagnosis of bacterial pneumonia, whereas recent studies have shifted to using PCR and other molecular methods that are highly sensitive at the expense of specificity. And then finally, we've shifted from identifying bacterial pathogens exclusively to now having tests that can identify respiratory viruses and other non-bacterial respiratory pathogens, often with multiple pathogens identified from the same child. And really, it makes it difficult to understand what is the clinical significance of identifying each of those pathogens in that child. So where are we right now with the microbiological diagnosis of pneumonia? I've tried to summarize it again on a single slide. So first, drawing your attention to the figure that's on the right. These are data from the PERCH study, which enrolled more than 4,000 children in 7 low and middle income countries. It was funded by the Bill and Melinda Gates Foundation. What I want you to take away from this figure is that in the post-vaccine era, so in the era with widespread use of Haemophilus influenza and pneumococcal conjugate vaccines, respiratory viruses are the dominant pathogens of pneumonia, and that includes in severe hospitalized cases. That's not to say that we shouldn't still look for bacterial pathogens. So in severe pneumonia, a blood culture should be obtained, but we should recognize that that's going to be positive in less than 5% of cases. So it's unlikely to give you your etiologic diagnosis. We now know, again, from a number of analyses that were performed in the PERCH study, that upper respiratory samples from children have low specificity except for certain respiratory viruses, particularly RSV and human metapneumovirus. So what this means is that if you detect a respiratory virus or a bacterial pathogen from the upper respiratory tract of a child with pneumonia, that does not necessarily imply that is a causative agent for that child's pneumonia, with a few of these particular exceptions. And again, that has a lot to do with these very high rates of respiratory virus detection in healthy children, as well as asymptomatic colonization of the upper respiratory tract by bacterial pathogens in healthy children. We know that induced sputum is useful for diagnosis of pneumocystis pneumonia and pulmonary tuberculosis, but we know that the yield of induced sputum for viruses and bacteria is really similar to nasopharyngeal or oropharyngeal samples. And then finally, lung aspirate with culture is specific for diagnosis of bacterial pneumonia, but it's an invasive procedure and requires technical expertise. Given these challenges in interpreting microbiological testing in children with pneumonia, there's been a lot of interest in developing a non-invasive serum biomarker that we could use to assist in our diagnosis and management of children with pneumonia. And there have been a large number of biomarkers that have been looked at in pneumonia. What I'm showing on this slide is really just a small fraction of those biomarkers. But in general, these biomarkers have been looked at to see if they can assist in discriminating bacterial from viral pneumonia and really informing whether antibiotics are necessary, and if these biomarkers can be useful for prediction of outcomes, and in particular mortality in patients with severe pneumonia. And the answer is yes, these biomarkers do have some ability to discriminate bacterial from viral pneumonia and predict outcomes, but unfortunately they haven't generally been superior to clinical algorithms or prognostic scores that have been designed and developed for this same purpose. And so really at this point, we don't yet have a biomarker that should be routinely used in the diagnosis or management of children with pneumonia, and this is still very much an active area of research. So let's talk now about treatment. And again, this is really based on, because of the differences in etiology, this is based largely on age. So for children older than 2 months of age, a number of studies over the past decade have shown that children with non-severe pneumonia without danger signs can be treated on an outpatient basis with high-dose amoxicillin for 3 to 5 days. And really, this is targeting the most common bacterial pathogens that cause childhood pneumonia, pneumococcus and susceptible strains of Haemophilus influenza. Children who fail this first-line treatment option can be referred to the hospital for IV antibiotics if that's available, if it's in a setting where that's feasible, or if it's not possible, potentially you could switch to coamoxiclavulanic acid, which gives you additional coverage of Haemophilus influenza, as well as some coverage for Staph aureus, which is the third most common bacterial cause of pneumonia in children. Children with severe pneumonia, so this is children with pneumonia accompanied by danger signs like an inability to drink or lethargy. These children should generally be hospitalized when possible and should be treated with ampicillin and benzopenicillin in combination with gentamicin for a total of 5 to 7 days. Children suspected of having Staph aureus pneumonia, and you might suspect that based on severe multifocal pneumonia or based on the presence of pneumatoceles. In those cases, you can treat with cloxacillin or vancomycin if it's available, in combination with gentamicin. HIV-infected children bear special mention, so these children are at higher risk of resistant gram-negative pneumonia caused by resistant gram-negative bacteria, and so you could consider using ceftriaxone as empirical first-line treatment of these children. And then, of course, we need to think about opportunistic infections in these kids, and in particular, empirical treatment for pneumocystis pneumonia with cotrimoxazole and steroids, especially in children less than 12 months of age, as well as ganciclovir, which is to treat CMV pneumonitis in very young infants, particularly those less than 6 months of age. Also important to remember that children with severe malnutrition are also at higher risk of resistant gram-negative bacterial pneumonia, as well as pneumocystis pneumonia. Let's talk now about the youngest age children, so kids less than 2 months of age. Ideally, in settings where it's feasible, these children would be hospitalized and would receive IV antibiotics. And this is really based on them having worse outcomes than older infants and children. Of course, that's not going to be possible in the vast majority of settings. And so, fortunately, a number of studies over the past decade have studied community or home-based treatment regimens for these children. One that's been used in a number of studies is procaine penicillin with gentamicin, given intramuscularly, once daily for 7 days. And then more recently, the African neonatal sepsis trial, or AFRINEST study, demonstrated that amoxicillin given twice daily for 7 days is an effective treatment regimen, even for young infants with severe illnesses, and that includes fast-breathing pneumonia. So again, hospitalization if possible, but there are treatment options, both intramuscular and orally, that have been shown to be effective in settings where that's not possible. One thing I was asked to talk about is, in particular, drug-resistant organisms that are starting to complicate our treatment of childhood pneumonia. So I first wanted to start with drug-resistant strep pneumo. So when antibiotics were introduced in the 1940s, we had over 30 years during which we really didn't see any resistance in pneumococcus to beta-lactams or other common antibiotics, with the exception of tetracyclines. And it was a rude awakening in the 1970s when outbreaks of antibiotic-resistant pneumococcus were seen in Durban and Johannesburg. Since that time period, we've seen increasing resistance to beta-lactam antibiotics, as well as macrolides, cotrimoxazole, clindamycin, and fluoroquinolones. And this has in part been, in some ways, related to introduction of pneumococcal conjugate vaccines. So these vaccines are very effective in removing serotype strains, vaccine strains from the community, and as a result, we've seen an emergence of non-vaccine serotypes in settings where PCV has been introduced. And a number of these non-vaccine serotypes have included strains that have had relatively high rates of drug resistance. And so in some ways, while these vaccines have been incredibly effective in preventing pneumonia, they have led to higher rates of drug resistance when pneumonia does occur. The mechanism of beta-lactam resistance in strep pneumo is altered penicillin binding proteins. You don't need to know the details of this, but what's important is that that mechanism of resistance can be overcome by giving higher doses of beta-lactams. So the recommendations in the previous slides I showed for treatment of pneumonia are administering beta-lactam doses that are high enough to overcome the levels of resistance that, to this point, we've seen in strep pneumo. That's true for infections outside of the central nervous system. We know that the resistance to beta-lactams that we're seeing in pneumococcus is very important for children who have infections that include meningitis and infections within the central nervous system. Another drug-resistant organism that is starting to cause problems for treatment of childhood pneumonia is macrolide-resistant Mycoplasma pneumoniae. So Mycoplasma pneumoniae is a common cause of pneumonia among school-age children, and it really can cause a broad range of illnesses, from self-limiting to life-threatening severe pneumonia, and can have also life-threatening extrapulmonary manifestations. We've seen over the past 2 decades rapid spread of macrolide resistance that has, not surprisingly, been associated with increasing use of macrolides globally, and in particular has been seen in parts of Asia, which you can see in the figure, a study in China and Japan that actually showed greater than 80% resistance to macrolides in isolates of Mycoplasma pneumoniae. So why is this a concern, particularly for children? Because while there are effective alternative therapies, tetracyclines and fluoroquinolones, in kids we try to avoid treatment with these antibiotics because they tend to have high rates of adverse effects. So tooth discoloration associated with tetracyclines. Of course, with doxycycline, the risk is lower, although that's not available widely. And then with fluoroquinolones, we're all aware of the adverse effects associated with them, including tendinopathy, prolonged QT, and they tend to just be more expensive in many settings. So this is likely to be an organism that is going to complicate treatment of pneumonia in older children and adolescents going forward. So I also wanted to finish up with policy efforts, and I hope during this talk you've gotten a sense that we really already have low-cost, effective interventions to prevent and treat childhood pneumonia, and we've made remarkable progress in reducing global child pneumonia by implementing these interventions more widely. But unfortunately, implementation of these interventions has really been challenging in the settings where the burden of childhood pneumonia is the highest. And this is, of course, a story that many of us have heard for lots of diseases, including tuberculosis. You can see in the figure on the right, these are proven effective interventions for pneumonia and the proportion of children that actually receive these interventions. So exclusive breastfeeding during the first 6 months of life is occurring in less than 40% of children. We are underutilizing these extremely effective vaccines that we have for measles, Haemophilus influenza, and against pneumococcus. Only a third of children are actually receiving antibiotics for pneumonia. And so we already have these effective strategies. We really just need to implement them more widely and get them to the populations that are most in need of them. Recognizing this, I did want to point out combined efforts of UNICEF and the WHO in developing the Enhanced Global Action Plan for the Prevention and Control of Pneumonia and Diarrhea. So this was released in 2014, and really recognizing the fact that a lot of the interventions that we use to prevent pneumonia are similar to those and implemented in a similar fashion to those that we use to prevent childhood diarrhea. And so this really provides a framework for countries in implementing these services on a national level. Many countries have taken that step and developed district, state, and national plans to reduce the burden of pneumonia, and certainly India is among those countries that has taken this step, while other countries have used recommendations from this action plan to implement pneumonia action items in their national child mortality programs. So again, we don't need a lot as far as technological advances to make significant gains, but I did want to highlight what I think are significant research priorities going forward for the global pneumonia research community. The first is already receiving a lot of attention and is a very active area of research, and that's maternal immunization for the prevention of infections among infants and prevention of pneumonia among infants. Proven effective are pertussis and influenza vaccine, and there's a lot of work being done right now to develop effective vaccines for RSV and group B strep that can be administered to mothers for the prevention of infection in their infants. We also need improved imaging modalities or point-of-care diagnostics for pneumonia. Chest X-ray misses far too many children with pneumonia and is really based on technology that is difficult to implement in the settings where the burden of pneumonia is highest. And so we need to investigate these alternative imaging modalities like ultrasound and newer modalities. The one shown in this slide is actually diagnosing pneumonia based on thermal imaging, which is another low-cost alternative. And so we really need to more thoroughly investigate these and see if they're viable for widespread diagnosis of pneumonia. Thirdly, we need to formally evaluate the safety of lung aspirate. And this may seem like we're going back in history a little bit, but if lung aspirate is shown to be safe, as it's believed to be, I think we really need to incorporate this a lot more into pneumonia etiology studies. Over the past decade, there's been remarkable work done in developing diagnostics for pneumonia, but use of clinical case definitions to include children in these pneumonia etiology studies and sampling of non-lung sites, so non-invasive sampling of these non-lower respiratory tract sites has really left us with fundamental unanswered questions as to which organisms do or do not cause pneumonia in certain clinical situations. And then as I've shown, viruses are really the dominant causes of even severe pneumonia at this point, and certainly development of vaccines for RSV and other respiratory viruses as well as therapeutics, holds great promise in reducing the global burden of childhood pneumonia. So on that, I'd like to remind everybody that November 12th is World Pneumonia Day. And so this is a day that really is designed to increase awareness, global awareness of pneumonia, and to envision us working towards a world where every child with pneumonia receives treatments that they need, and effective vaccines and other preventative interventions that we have are reaching children no matter where they're born. Thank you very much.
Thank you so much, Matt, for the presentation. I'll now invite both presenters for questions or comments from the audience. Questions or comments? Yes, somebody with a microphone, please. Can you help?
I have a question for you, Matthew. You showed one slide where there are some policy changes made by various governments. That's the 2013 data. So regarding the immunization, now many countries have also introduced the pneumococcal vaccine. So is there some recent data beyond 2013 which has also incorporated these changing policies over the last 5 or 6 years? Thank you.
Yes, thank you for that question. I like the figure, but you're right. Some of the numbers are several years old in that figure. It's data from 2013. So there has been some progress in some of those risk factors. Exclusive breastfeeding rates have improved. Certainly immunization coverage rates for Haemophilus influenza and pneumococcal conjugate vaccines have risen quite dramatically over the past 5 or 6 years. So those data are available. As you might imagine, there's still quite dramatic regional variation in how effectively and how widespread these interventions are being used. And so that's, I think, something that needs continued work. Certainly, in general, for pneumococcal conjugate vaccine, uptake has been higher in African countries than in some of the countries in Asia. And so, that's something certainly going forward that needs specific attention.
Thank you. There's a question right behind you.
Thank you. My name is Chungu from Zambia. And my question or comment is to Ains. Regarding asthma epidemiology, definitely the Western statistics will have a higher prevalence due to things of hygiene theory, and also, but also there's issues of surveillance also in the lower middle income countries. Because anecdotally, we've been seeing a lot more asthma, especially the preschool asthma that you talk about, but then there's very poor collection of data. But then there's some evidence that I came across some 2 months ago that showed that allergen prevention is not as linked to exacerbations of asthma as we thought. And that there was you can't hear me clearly. I'm saying there's data that came out to show that allergen prevention in asthma is not as impactful as we thought on exacerbations in children. And so what's your comment on that? Because it's among pediatricians, it's a strong management perspective and parents really go out of their way to get rid of pets, to, like mold and mite. But then what's your comment on the data that's emerging that shows that allergen exposure is not so cardinal in avoiding exacerbations?
Thank you. I'm a bit hard of hearing, so I'm just going to ask my colleague here to cover the key points of your question. And you're from Zambia, is that right? Thank you.
I can actually just restate them just so we're sure that I'm phrasing it. So I think the first point was pointing out that there's also issues around surveillance in low and middle income countries and maybe detection of asthma in those settings. And then the second point was about...
We'll just deal with that bit first. So I agree that, in some countries, for example, China, I think about 15 years ago, in one study, there was nobody diagnosed with asthma in a particular state there whatsoever. So the understanding that respiratory difficulty could be due to asthma is still patchy around the world, that is a diagnosis to be considered. So I absolutely agree with you. So this is where training, so we're talking, what we're doing in Ghana is global surveillance at a population level, and we're basing our assessment of asthma on symptoms of asthma, so we're not dependent on the diagnosis. And what we do find is the variation around diagnoses relating to current wheezing around the world. So, but within countries or within settings, it varies tremendously. It's much more likely you'll be diagnosed with asthma in New Zealand if you've got wheezing than it is perhaps in the Zambia. And in fact, the opposite can occur. You can maybe a bit of an overdiagnosis of wheezing in some of the countries where asthma's been much more well known about for a long time. So this comes back to health leaders in the country understanding that asthma's an issue and training health professionals who are working in all the settings in your localities so they can recognise asthma, diagnose it, and then offer the treatment. So that's a very important issue that you've raised. Thank you.
The next question was pointing out that there have been recent studies that have suggested that allergen avoidance in patients with asthma may not be as effective a strategy for preventing exacerbations, and just your thoughts on that.
Yes, well, my thoughts on that are, I think that I'm in agreement with that, generally speaking. For example, in New Zealand, the commonest allergen is house dust mite. The level, we're very humid and not as warm as India, but we're a temperate, humid environment being surrounded by water, and house dust mites love to live there, as we do. So measures to reduce house dust mite in my setting, they do reduce the level of house dust mite, but still to a high level. So to actually get allergens down, where allergens are prominent, to get them down to a level even with the strict house dust mite avoidance measures is difficult. So that's one thing to say. Allergens do vary around the world, but every place has got its own allergens. But the data I showed, well, the data I alluded to, I didn't show you the data from ISAC phase 2, which was more in-depth studies looking at atopy and IgE skin prick test, showed that atopic features were much less commonly associated with asthma in low and middle income countries. So I think that each setting you need to sort of think what's going to be the right thing for your setting. So if people have got, I think it's important to ask about triggers, ask about allergic triggers, but if they're not forthcoming, and if they're forthcoming, do what you can to avoid them, but most asthma exacerbations are actually caused by viruses. I think that's probably true for all ages. So that some of these incidents we can't prevent, and therefore we need to use good preventative management therapy. Thank you.
Thank you. Next question. Yes, please.
I'm Okada from Japan, RIT. So my question goes to Matthew.
Could you please speak a little bit louder?
I'm sorry, I can't hear you.
Yeah. So to him. So okay. So in terms of, you just briefly introduced the lung ultrasound test to detect pneumonia in kids. Is there any data for targeting adults? This is for pediatricians, but for adults, such a test or research work to detect such abnormal findings in the lungs using ultrasound in addition to the chest X-ray or CT scan in adults field. This is one thing. And another thing, you just also briefly introduced such a CAD, computer-assisted diagnostics on chest X-ray in kids or pediatrics, kids. Children. So is there any, I know this is very difficult area to do it, but how promising it is, I'd like to know. So far, the CAD is using for like targeting the adults only. So, but now you are expanding the kids using such a CAD. I mean, computer-assisted diagnostics on chest X-ray film. So, how far it would be available in the world? Two things, please.
So I think I'll start with the second question,
Yeah.
and I may need you to repeat the first one just because I couldn't quite hear it. But was the second question, are there data for use of computer-assisted interpretations of chest X-ray in children?
Yeah.
Yeah. I'm not aware of specific studies that have looked at that in children in particular. Certainly there's a lot of promise for that in adults, or a lot of work that's being done on chest X-rays in general. And I'm not sure anything in particular is being done on kids. But I think that technology holds a lot of promise because, and I think using machine learning algorithms and other computer-based approaches to interpreting these images is going to be really critical for either more widespread use of radiography or things like thermal imaging or even ultrasound, because I think we know there's a lot of variability in interpretation of chest X-rays and of ultrasound images, and I think those approaches really hold the potential to try to minimize that.
Yeah, my first point was on the lung ultrasound, lung ultrasound, which is a very new area for me. So would you just elaborate about that? And then also, is there any data on targeting adults also, not only kids? So is there any data? If it is available, I'd like to know. Thanks.
Yeah, so actually the studies that have been done have been mostly in adults at this point.
Oh, really?
That's right, yeah.
Okay.
And so there is good reason to think ultrasound could be particularly useful for childhood pneumonia. The smaller thoracic size of kids makes it easier for you to get high-resolution images. It seems to have sensitivity and specificity that is comparable to or even superior to chest X-ray.
Really?
But the problem with all of these studies is you're comparing to a gold standard that is chest X-ray.
Okay,
And so, or is some other, provider diagnosis of pneumonia. And so we really don't have a great diagnostic and a great way of sort of, a gold standard for pneumonia for these tests. But I think it's promising technology. You're actually looking for, basically the lung looks solid on X-ray, and so it looks a lot like liver looks. And just as they used to describe pathologically 50 or 60 years ago when a patient died of pneumonia and the lung looked like liver, this hepatization, you see the same sort of features on ultrasound. And so that's what you're primarily looking for. There are also more subtle features that you can see in very early ultrasound that has to do with different alveoli filling at differing rates in certain areas of the lung.
Thanks, sir.
So we've come to the end of this session. Our time is out, and I want to thank everyone for attending the session. Let's give a round of applause to our presenters. I think they're available. If there are any issues you want to discuss with them, you can catch them in the next sessions or in the corridor. Thank you so much, everyone.